Thank you, everyone, for joining us today. Welcome. Good afternoon. And I am Ashonda St. Jean, an associate professor of obstetrics and gynecology, but also an advisory board member for the Emerging Leaders Program. It is my pleasure to showcase the wonderful work of our 2025 cohort of Emerging Leaders Fellows. The Emerging Leaders Fellows Program was created in 2023 for diverse early career professional to enhance their skills, tools, and habits to amplify their leadership qualities by one, shaping the future of HPV vaccination with best practices and outreach, also capitalizing on monthly mentoring and learning opportunities. And lastly, networking with national HPV vaccination and public health leaders. This year, despite the challenges to HPV vaccination, the fellows have been able to accomplish so much. And because of this, we relish in the opportunity to showcase their work. This group consists of 16 fellows from across the United States who have a passion for improving HPV vaccination. During the next hour, you will hear from four groups on their capstone projects. Each project is focused on a priority population relative to starting HPV vaccination at age 9. Today, each group will present within 15 minutes. So please enter all your questions and comments in the chat or in the Q&A, and we will answer all questions following the presentations. So just before we start the showcase, I really want to just address a few housekeeping issues. One, today's showcase will be recorded. The link to view the recording will be shared with all who have registered. If you have any issues during today's seminar or have any questions for our presenters, please use the chat. To ensure that there are no disruptions during the presentations, we please ask all the participants to be muted, or we will have to mute you by the host. And again, once again, we will have a Q&A portion at the end, so please put all your questions in the chats. And also in the chat will be our bios as well. So to start us off, we will have our first group who will present on HPV vaccination among medically complex children. So let us please give a warm welcome to Lauren and Anne, and their bios are in the chat. Thank you.
Hi, everyone. Um, I am Ann Zeitz and my partner Lauren Ing, and I will be presenting on our project and approach for endorsing HPV vaccination in children with medical complexity. Next slide, please. Thank you. And go ahead and advance to the next one. Thanks. So today I'll briefly define the special population we're focusing on, share background on HPV vaccination in this group, and highlight key factors contributing to reduced uptake. This will set the stage for the action plan and next steps. Next slide. The American Academy of Pediatrics defines children with medical complexity, or CMC, as a subset of children and youth with special healthcare needs who have multiple significant chronic conditions, functional limitations, and high healthcare utilization. Although children with medical complexity represent less than 1% of U.S. children, they account for more than one-third of total pediatric healthcare costs. This reflects how intensive and ongoing their care needs are. Families often navigate frequent appointments, multiple specialists, and fragmented systems, which makes integrating preventive care, including HPV vaccination, more challenging but also more important. Next slide, please. For this project, we use a simplified definition of children with medical complexity. A child with medical complexity is a child who has two or more medical diagnoses, is followed by three or more pediatric subspecialists, and has functional limitations requiring significant caregiving needs. This definition helps us consistently identify a population with high care complexity and frequent healthcare interactions. Next slide. HPV vaccination coverage among children and adolescents with medical complexity is limited. One study of patients ages 9 to 26 with two or more systemic inflammatory diagnoses found significantly lower HPV vaccination initiation compared to those without these conditions. Many of these patients were receiving immunosuppressive therapy. Because persistent HPV infection is more common in immunosuppressed individuals, prevention through vaccination is especially critical. Despite this increased risk, another study found that many pediatric subspecialists do not routinely recommend HPV vaccination to children with medical complexity. Next slide, please. Several factors contribute to lower vaccination in this population. HPV vaccine is not often available in subspecialty clinics where these patients receive much of their care. Some providers may hesitate to offer HPV vaccination to chronically ill children due to concerns about adverse events. Families may also prefer to avoid additional interventions that are not perceived as immediately necessary. And research suggests that acceptability of HPV vaccination among parents of children with special healthcare needs is lower than in the general population. These barriers highlight the need for targeted strategies focused on access, provider education, and family-centered communication. And with that, I'll turn it over to Lauren to walk through the HPV vaccine action plan and next steps.
Thanks, Anne. So we created this action plan. It's an HPV vaccine education toolkit for pediatric providers, basically geared towards children's hospitals or tertiary care pediatric care centers or health organizations or practices that have pediatric subspecialists or multidisciplinary practice. Next slide. Part of the action plan, we have some strategies. Action 1 is engaging a pediatric organization leadership in HPV vaccination efforts and endorsing HPV vaccine starting at age 9. Action 2 is creating a pro-vaccination environment, especially in our current climate today. This is super important. And expanding opportunities for vaccination for children with medical complexity through the pediatric subspecialists. Action 3 is educating these pediatric subspecialists and encouraging them to make effective HPV vaccination recommendations. And Action 4, using recommended evidence-based strategies to answer questions about HPV vaccine, something that subspecialists may not be well-versed in. And Action 5, evaluate pediatric subspecialist HPV vaccine education and HPV vaccination rates among children with medical complexity. Next slide. So Action 1, engaging a pediatric organization, department, leadership, starting from above for vaccine efforts and endorsing HPV vaccination starting at age 9, developing a policy to start HPV vaccine at 9. And one of the resources that was suggested was using the American Cancer Society and National HPV Vaccination Roundtable call to action letter, which urges healthcare providers to treat HPV vaccine as essential career cancer prevention and aiming to start the vaccine at 9. Thus, then, communicating this policy to all pediatric providers, including pediatric subspecialists, and determining if HPV vaccine can be given in pediatric subspecialty offices, and if not, trying to develop a workflow where they can, and then determine baseline HPV vaccine rates in children with medical complexity, ages 9 to 13 years, and share that data as baseline data. Next slide. So Action 2 is, again, creating that pro-vaccine environment through a cancer prevention approach. Again, which is especially important because culture does come from above. And we want to organize an HPV, maybe like a cancer survivor speaker or a panel to inspire providers that this is very important. Emphasizing the need for dual recommendations by both pediatric subspecialists and primary care physicians, and then emphasizing a collaboration within the pediatric division. So between primary care providers who are more versed in recommending vaccines and making accountability partners with the subspecialists. Next slide. So Action 3 is our education piece. So when you think about pediatric subspecialists, basically their knowledge or fund of knowledge is is within this small niche. So if you're a pediatric pulmonologist, you're well versed on lung diseases. You may not know much about HPV infection or HPV related cancers. So our first step is to kind of review the literature, look at, the reduction of risk of cervical cancers and other cancers, and then kind of educating more about the vaccine itself, discussing the vaccine series and the timing. In my current practice, we are following the AAP guidelines on vaccine series and timing. And then just using this information to encourage the subspecialists to make effective HPV vaccine recommendations. So step 2 kind of ties into action number 4 about implementing evidence-based trainings. One training that was recommended also is not evidence-based, is the announcement approach. This is a well-studied evidence-based training that increased HPV vaccine initiation by 5% in 3 months among adolescent patients. And it uses presumptive announcements and steps to follow up with parents with concerns about HPV vaccine. Another approach or evidence-based approach is the 3Cs intervention and motivational interviewing. The 3Cs focus on confident, concise, and consistent healthcare provider recommendations. And then motivational interviewing addresses vaccine hesitancy, fosters trust, and explores vaccine concerns while providing education and knowledge to parents and patients. Next slide. So action 4 is basically kind of building up on that. Having the subspecialist kind of be more comfortable in talking to patients and parents of complex children, and understanding like the risk from the parent perspective, knowing that the benefit of cancer prevention outweighs any potential risk of any adverse event due to the vaccine, and we know that the vaccine is safe and effective. We also need to try to reframe parent fears, fear the cancer or the disease and not the vaccine itself. And that this patient population, especially when Anne was talking about, those with multiple diagnoses and on immunosuppressive therapies, they're at more risk of persistent HPV infection. So, added to that risk is acquiring an HPV-related cancer. And then again, like I said, addressing vaccine hesitancy through motivational interviewing, asking open-ended questions, asking for permission to share information about vaccines, and then offering credible vaccine resources for parents. Oftentimes I have patients or parents tell me that they read something on social media, but offering these credible vaccine resources is super important because we want to spread accurate information and not misinformation. Next slide. So action 5 is probably the hardest section. Evaluating pediatric subspecialist HPV vaccine education and HPV vaccination rates among children with medical complexity. So analyzing and improving those strategies, determining HPV vaccine among this population that are given among the pediatric subspecialists, sharing the data, give provider feedback, and reevaluating areas for process change. And promote a culture of continued learning and improvement, whether that's through quality improvement and just improving the HPV vaccination rates among this complex group. So that may include, follow-up interventions such as HPV second dose vaccine reminders as part of the toolkit to parents, and then implementing standing orders for HPV vaccine and EMR changes to help with workflow for providers, because it is a very high volume service in pediatrics. So anything that could help providers or send reminders may help increase rates. Next slide. So this is a continual work in process. The premise of this project kind of stemmed from understanding physician and parent perspectives of HPV vaccination in children with medical complexity. And first, before I move on to our next steps, I do have to acknowledge my team, Dr. Linda Mermelstein and Annalia Trask, who are part of the Stony Brook Cancer Center Office of Community Outreach and Engagement. They've been helping me with this process. So next slide, I'll go into it more. So we have set out to distribute IRB-approved surveys, physician perspectives, where we survey physicians who see and care for children with medical complexity, and just kind of understand their perspectives and whether or not they do recommend the HPV vaccination during visits. And then also determine, what are the gaps in knowledge? What can we focus on? How can we help them communicate better to patients? And using that tool or those survey results, we can enhance our current education toolkit and action plan so that we can better educate. So that's one part of the surveys. And then the second part of a parent perspective. So we're surveying parents of children with medical complexities, kind of delving into, what if there is vaccine hesitancy, if they have history of vaccine delaying or intent on, giving the HPV vaccination, what kind of sources do they need, and just kind of receiving input from their perspective. So that way we can try to incorporate it again into our provider education toolkit and action plan for the subspecialists. So both of those actually, unbeknownst to me, needed an IRB expedited review. I thought it would be exempt, but there were some sensitive questions on there that my institution's IRB wanted a little bit more in detail review. So that is currently in process. The surveys are made. That's where Annalia and Dr. Mermelstein have been helping me. And now we're kind of working on finalizing in the red cap surveys and then distributing them would be the next steps. Next slide. So these are our references. Next slide. There's a lot of references, sorry, and they're tiny. And I know we're not supposed to take questions now, but this is our contact information. If you have any pressing questions or further detailed questions, you can always email us. Thank you.
Thank you so much, Anne and Lauren. I think also what's important is that there is just a lens at looking at children with medical complexities and how we can facilitate HPV vaccination. So thank you for that very thoughtful presentation, but also kind of really having action plans and toolkits and understanding that there is vaccine hesitancy and how we can address it with some pearls that you provided. So thank you. Now, we will now have our second group who will be presenting HPV vaccination among childhood cancer survivors, 6 months post-treatment. So please let us have a warm welcome for Pragya and Blake. Thank you so much.
Thank you, Dr. Jen. Blake and I are excited to share our work with you all today. We focused on improving HPV vaccination among childhood cancer survivors as our special population. We will go through background information, our approach, and resource that we developed. Next slide, please. With the development of technologies and supportive care, childhood cancer survivors' survival rate has significantly increased. As shown in this figure, the 5-year survival rate for childhood cancers has increased to more than 85% from around 60% in 1970s, leading to a growing population of childhood cancer survivors. Currently, there are more than 500,000 childhood cancer survivors living in the United States. Though the survival rate for childhood cancers has increased, these cancer survivors face treatment-related late effects, including long-term side effects and chronic health complications, and also higher risk of second malignancies. Next slide, please. Childhood cancer survivors are at higher risk of developing HPV infections and HPV-related second cancers, potentially due to the effect of aggressive cancer-directed therapy, which weakens their immune system. Both male and female childhood cancer survivors are at higher risk of developing HPV-related malignancies. However, more than 90% of these malignancies can be prevented through on-time HPV vaccination. Next slide, please. Evidence shows that HPV vaccination is safe and effective in childhood cancer survivors, similar to that of the general population. The Children's Oncology Group long-term follow-up guidelines recommend a total 3 doses of HPV vaccine series for childhood cancer survivors, regardless of their age at first vaccine dose, beginning 6 months after they complete their cancer-directed therapy. The recommendation for childhood cancer survivors are shown in the red box here. Next slide, please. Though the research shows that childhood cancer survivors are at higher risk of HPV-related malignancies and HPV vaccination is safe and effective in cancer survivors, these cancer survivors are less likely to be vaccinated against HPV compared to that of the general population. As shown in this figure, we see that for 1 dose, 2 doses, and 3 doses, there is significantly lower proportion receiving HPV vaccination among childhood cancer survivors than general population. Next slide, please. Next slide, please. Some of the reasons for lower HPV vaccination coverage among childhood cancer survivors include lack of provider recommendations, vaccine hesitancy, vaccine-related information deficits, safety concerns, and family decision-making processes. So here in this slide, evidence shows that healthcare provider recommendation is the strongest predictor for HPV vaccination in childhood cancer survivors. As shown in this figure, those who did not receive provider recommendation were about 10 to 11 times more likely not to initiating or not receiving the HPV vaccination compared to those who received provider recommendation. This clearly shows the critical role of healthcare providers' recommendation. Childhood cancer survivors and their families trust healthcare providers, especially oncology providers, because they have already built a strong trusting relationship during their cancer treatment. As a result, they prefer to receive vaccination recommendation or vaccination-related information from their providers. Next slide, please. Next slide, please. With all this background information and also understanding the critical role of healthcare providers, for our project, we wanted to focus on the resources for healthcare providers, which would support clear communication regarding HPV vaccination with cancer survivors and their caregivers. Then we went through the various available resources. We went through previously published studies focusing on HPV vaccination among childhood cancer survivors. We reviewed the guideline from Children's Oncology Group, and also we went through several other resources as we have, for example, at St. Jude Children's Hospital, we have resources in HPV cancer prevention program related to childhood HPV vaccination in childhood cancer survivors. And also we went through the resources that are available at National HPV Vaccination Roundtable to thinking about what could we build which would be most relevant to the providers in our population. So further, we also discussed with the healthcare providers and experts in this area to understand what might be the best resources for healthcare providers that we could develop and would be most relevant for their daily practice. Next slide, please. Then we, based on the literatures we reviewed, we found that there was a clear lack of clear and consistent guidelines regarding HPV vaccination, especially focusing on childhood cancer survivors, lack of timely collaboration and communication between oncology care team and primary care providers. As we know, several survivors, after they complete their treatment, they go back to their providers in their community, and the communication between oncology team and primary care provider is critical. And also lack of recommendation, which we already saw. And we found that there are limited strategies focusing on HPV vaccination coverage among childhood cancer survivors. Next slide, please. Now, with this information, I will pass it over to Blake, and he will continue with what we found after discussing with healthcare providers and also the resource that we developed as our capstone project. Thank you.
Thank you, Pragya. So a lot of our discussions with our healthcare providers that we reached out to, mainly oncologists that serve this population of childhood cancer survivors, really focused around what key facilitators were, ensuring that these oncology providers could provide the correct information to the parents as well as the patients. And so a lot of the information that we heard from them were around the fact that, as we know, HPV vaccination is cancer prevention, that this is still a way to protect survivorship and reduce the risk of second-hand cancers, which we heard Pragya discuss earlier, as well as trusting in evidence-based guidelines and a willingness to recommend the vaccination itself. Some of the barriers, however, that came up were really around the unclear role of who was to provide this information. So whether that was the oncologist who was working with the patients and the families, or whether this was in the transition to a primary care physician. And so we really looked at that barrier as well as the timing for the vaccination and the workflow and time constraints within both systems as a key component of what we ultimately put together in the toolkit for ensuring that the guidelines were something that could be clear, concise, and easy for providers, oncologists, as well as primary care physicians who are working with these childhood cancer survivors to learn and ensure they were going to hopefully implement them in their practices and continue to train as many individuals and providers as possible. Next slide. Next slide. So we looked at something within the concept of also what we wanted to provide is when we spoke to these oncologists, many of them are really strapped for time. This is an important feature of what they all said would be a part of their discussions with the patients. However, we really wanted to design something that was engaging in a very clear, concise way and easy to understand. And so a lot of that focuses around summary of the evidence that was discussed already, supporting providers to deliver that strong and consistent vaccine recommendation using evidence-based communication strategies, as well as additional resources like checklists, EMR, EHR prompts, and potentially other reminder recall systems that would help to increase HPV vaccination initiation completion within those systems. Also, we were really looking at increasing vaccination rates, and so that was a major focus of the toolkit. Next slide. Components of the toolkit really focus on what we went through as far as the background, setting up, ensuring that the physicians understand the reasons why we were wanting them to implement additional strategies in their clinics and practices, as well as really discussing the role of the healthcare provider between not only just what they should be providing information-wise to the patient, but how they should be following up and ensuring communication between not only the oncology side, but also the primary care side. We focused on the announcement approach training within the toolkit as one of the evidence-based interventions, but as our colleagues already mentioned from the previous presentation, there are a few others that could be added to this list as well. Really looking at the potential barriers and strategies to overcome within HPV vaccination. So ensuring that we discuss within the toolkit some of the things that we've noticed in the literature, as well as discussing with oncologists as to reasons why HPV vaccination may not be discussed as often within these settings. And then really focusing on how can we help physicians and oncologists monitor the progress and hopefully set up some sort of evaluation of how to ensure these patients, as they travel between oncology and primary care, can be followed and ensure their vaccinations are up to date. Next slide. So as a component of the toolkit, the role of the providers really wanted to focus on initiating the conversation early after completing the cancer therapy, and having that strong recommendation, but also focus on connecting between the primary care side and vaccination providers, as many of the oncology clinics, depending on where their setting is, whether that's a cancer center or a federally qualified health center or other community clinic, may not have the vaccination available. And so this is not only one of the barriers that we noticed in discussions with these providers, but also one of the things that we wanted to help build into the toolkit itself to ensure that this connection between primary care and oncology was something that is discussed as a component of how to track ultimately these patients as they move through the system. Next slide. As I mentioned before, this is the announcement approach that we focus on in the toolkit itself, adapted for cancer survivors. But it focuses really on the presumptive statement and then connecting with counseling, making sure all questions are asked, as well as allowing them to voice any feedback on the decision around the HPV vaccination. And then the last component is really the concept of making sure that they can try again if they are declined. And a key component of that is whether or not that is actually recorded in a way to evaluate in further analysis later on. So making sure the EMR, EHR system can actually take in that a patient has declined today, but then it will hopefully pop back up in a feedback loop at some point in the future, their next visit or another time that they're interacting with that patient in their setting in the oncology center, but also possibly in the primary care setting, so that conversation can be had again, and you can revisit that recommendation at the next time. Next slide. Finally, some of the next steps around finalizing the toolkit based on the feedback from our healthcare providers, as well as introducing the toolkit into oncology survivorship care and primary care settings, developing hopefully a survey that we can utilize to help ensure the usability and the feasibility of the toolkit itself, and then how we can adjust that toolkit in the future to ensure that it's meeting the needs of providers, both on the oncology side, but also on the primary care side. and ensuring this aligns with current survivorship care workflows. And then finally, once we get the toolkit finalized, we hope to disseminate through professional networks and conferences and publications, as well as continue to do an evaluation, which I'll talk about in the next slide. So we hope to focus on the process as well as outcome evaluation, ensuring we can hopefully collect information around how far this toolkit reaches, as far as how many providers are receiving the toolkit, potentially read the toolkit, how many providers were engaging, the frequency of accessing the toolkit, as well as the feasibility on the feedback from providers on clarity, usability, acceptability. We also really want to understand confidence in recommending the HPV vaccine, and if this actually helps oncology providers or primary care providers increase their self-efficacy as they discuss the HPV vaccination with their patients. A lot of the data sources that we're looking to potentially interact with, there's EMR, EHR data, as well as immunization registry data, and then self-reported ratings using surveys that we discuss within the toolkit itself, and additional interviews or brief assessments with providers that are utilizing the toolkit. Next slide. Next slide. We just want to acknowledge and thank, next slide. There's our references for the toolkit, and then our mentor, Dr. Shannon Christie, as well as Gabby, Christina Turpin, Kara Long, and the rest of the American Cancer Society National HPV Vaccination Roundtable. Thank you very much for letting us present today on our project.
Thank you so much, Blake and Pragna. I really just want to highlight that, really putting a lens on a cohort of childhood cancer survivors is so important in understanding how you can really connect and counsel as oncologists, but also offering the tools that is so helpful, but also identifying what are the barriers, how do you kind of make those key point discussions. So thank you so much for this presentation. Excellent again. And so as we continue to move on in our programming, we will now have our next group, where this is our third group. Let us please welcome Talisha and Morgan as they discuss community health worker supported strategies to promote HPV vaccination for pediatric survivors of sexual abuse. Thank you so much.
Thank you. Good morning, everyone, and good afternoon to some of you as well. My name is Talisha. I am a community health worker and a community health worker instructor based in Houston, Texas. And then also my partner, Dr. Morgan Levy. She is with the University of Kentucky. And so we'll be talking about our project today, and just thank you for the opportunity. So next slide, please. So when we were thinking about our project and we decided on populations that are like most at risk when we're thinking about HPV vaccination, we wanted a group who not too many people have touched. It's not something that would just be kind of easily findable. We wanted a population where, people, again, not so much research has been done because we want to create an impact and we want to utilize community health workers in more new and innovative ways that they've never been used before. And so we decided on pediatric survivors of sexual abuse. And so when we first started, kind of defining what a pediatric survivor of sexual abuse is, we saw that defining it as children 18 and under was a little too broad. And so when we started looking at who's more at risk in that pediatric population, it includes children with disabilities, those who are in foster care, minority youth, and LGBTQ plus youth. And so HPV vaccination at age 9 is critical. It's a critical preventative measure against those HPV-related cancers, and utilizing community health workers because they are bridges that can bridge between those vulnerable families and clinical care. Next slide, please. So when we look at the demographic patterns in that pediatric population, girls, approximately 1 in 4 have a higher reported prevalence of sexual abuse compared to 1 in 13 boys. And as we found in our research, with boys, there is more underreporting. And so that remains a concern for us with this project. But also, children with disabilities are 2 to 3 times more likely to experience sexual abuse due to their increased dependency needs and also their communication barriers. When we look at race and ethnicity, Native American children, Alaska Native children, and Black children, specifically African American children, they experience disproportionately higher rates of sexual abuse that is, influenced by the structural inequities and systemic disparities. And then lastly, LGBTQ plus youth are approximately 3 times more likely to experience sexual assault due to the heightened risk linked to family rejection and instability. Next slide, please. So, in addition to the demographic disparities, situational and environmental conditions may increase vulnerability to sexual victimization among youth. So, when we look at foster care and group home placement, youth that are in and out of care often experience placement instability, multiple caregivers, and reduced continuity of adult oversight, which may increase vulnerability to exploitation or abuse. The trauma-dense community environments, those exposures to those adverse childhood experiences including prior abuse, household instability, caregiver substance use, and exposure to community violence that has been associated with increased risk for future sexual victimization. And youth with those higher ACE scores, they may face compounded risk due to cumulative trauma exposure and reduced protective supports. And additionally, individuals, because these children are going to grow up to be adults, adults that have a high history of those ACEs are less likely to engage in preventative healthcare services across the lifespan, including cancer screening. And then lastly, the cultural silence and the stigma around sexual health. So in some communities, specifically, I'm speaking from the African American perspective, there are cultural norms that emphasize privacy, often reflected in the belief of what happens in this house stays in this house. And that may discourage open discussion of sexual abuse. And so this emphasizes on the family protection and internal conflict resolution that can delay disclosure, it can limit help-seeking behaviors, and it can reduce opportunities for early identification and intervention. And so now I'll pass it over to Dr. Levy to talk about that clinical provider perspective.
Thank you, Talisha, for getting this started. Next slide, please. So today we're going to also talk a little bit about the role from a clinical provider perspective in terms of how to implement interventions such as using community health workers to facilitate HPV vaccination in a high-risk population. Next slide. A lot of what we wanted to focus on, at least from my side, as somebody who is in the clinical side frequently and sees the ways that we can reduce cognitive load for clinicians to facilitate increased access to care, is to use things such as EHR alerts. I've seen this used really well in emergency rooms, in particular with things like if a patient comes into the emergency room and they're over age 65 and they have a fall, there's automatic alerts that go out in order to make sure that things like fracture risk or concerns for a safe home environment are part of the consideration when a patient comes in and can often help facilitate access to resources, follow up with the healthcare system, and ensure that we get a comprehensive evaluation and opportunity to capitalize on ways to help our patients get better care when we see them. And this is particularly important in a population like this where they may have less contact with the healthcare system and can fall through the cracks. Particularly, these sorts of systems are really effective when they're paired with a proper education to ensure that those who are utilizing these alerts do not get alarm fatigue and know how to utilize them to better care for their patients. Next slide. The idea behind this was to figure out the best way to ensure that patients presenting to the emergency room after suspected sexual abuse, specifically in the pediatric population, are triaged appropriately to facilitate follow-up for HPV vaccination and connection to a community health worker. And so the overall flow of this sort of intervention would involve a automatic trigger in an EPIC or an electronic medical record, depending on the system, when a patient who is pediatric, age 9 and above, presents to the ER with a suspected sexual abuse. The thing that it would do would be actually to check for HPV vaccination status and to see whether the records indicate complete vaccination or incomplete vaccination, which would lead to entry into this pathway for connecting with resources and care. Next slide. The importance of having this sort of alert is to make sure that a provider thinks about things like discussing the HPV vaccine with their patient, ensures that things such as an STD and an STI screen are ordered, and also informs the patient and their family member about the follow-up and to talk to the caregivers in terms of obtaining consent for future contact and setup. Simultaneously, the CHW would be notified to alert them that there's a patient who is being entered into this pathway and that their parent or guardian or family member consented, and also to make sure that we are getting background on different care gaps that the patient has experienced in the past or may moving forward. Next slide. Other things with implementation that would need to be addressed would be to make sure that state vaccination records are integrated into the EHR, because not in every state, that's not always the case that the state vaccine record actually is integrated. And this is especially true if a patient is not in the state that they've spent all of their childhood in, to make sure that we have the most complete records also. And then make sure that we think about other services we might need to have linkage for, particularly counseling, as this patient has also gone through a traumatic event along with their family and their loved ones, and also a social work consultation to make sure that any resources are addressed that are needed. And then finally, really to make sure that we're not falling through the cracks, to make sure that we have a way as a fail-safe to make sure timely follow-up gets arranged. Next slide. Finally, the ER clinician would also play a role in counseling, recognizing principles of trauma-informed care. As Felicia had mentioned earlier, many of these patients are those who have experienced additional adverse childhood events, and it's very important that we account for that when we work with our patients and are talking to them about something like cancer prevention while recognizing the fact that they have also just been through a traumatic event at the same time. Really making sure that we do things like introduce our CHW that would be involved in the patient navigation process as a trusted community member to help them with their care and facilitating next steps, obtain a consent form for their follow-up contact, and then in order to remind the ER clinicians about this workflow, to have a QR code for people to scan to remember what the program is about. I've seen this implemented well in the hospital and used frequently. And I find that those are the things that I myself, even working with patients, actually use more because they're accessible to me and I remember to do it. Next slide. And now we're going to move to Talisha to talk about the community provider perspective.
All right, thank you. So next slide, please. So with this project, as Dr. Levy already kind of mentioned, we want to utilize community health workers to deliver that trauma-informed HPV education and address that low vaccine confidence among pediatric survivors of sexual abuse and their caregivers. Now, it can vary from state to state when it comes to community health worker training. So we kind of thought about it from the Texas perspective because Texas is kind of the gold standard when it comes to community health workers as far as education and training. And a lot of training programs here in Texas offer that trauma-informed care training for community health workers. And so community health workers also, they provide the culturally responsive, counseling to clarify any common myths surrounding HPV vaccination and reduce any stigma associated with preventative care as well. Community health workers, they also facilitate or coordinate care by facilitating appointment scheduling, any, follow tracking, linkage to vaccine for children providers, or if the child already has a medical home, they'll refer them to their medical home. In addition, community health workers, we work to mitigate the structural barriers, including any transportation challenges, any language access, if they have any issues with like consent forms, the community health worker can help with that as well, and any insurance instability that may prevent any vaccine initiation or completion. Next slide, please. So while these are functional roles of community health workers that they serve within, this project, it is equally important to make sure we understand why this workforce is particularly effective in engaging at-risk populations. And the main reason is because community health workers, they often share the lived and cultural experiences within the communities that they serve, fostering trust among families who distrust traditional healthcare systems. A lot of my fellow community health workers that I, kind of communicate with, a lot of them became community health workers because they were pediatric survivors of sexual abuse. They grew up in low income households. So they have that lived experience, and that's why they became community health workers. So they could try to help someone else. Again, like we mentioned before, their trauma-informed training, it enables them to approach those sensitive topics here in Texas specifically, including the sexual abuse history and, of course, HPV prevention in a way that will minimize re-traumatization. And then also, community health workers are everywhere. They're in social services, they're in public health, they're in, the clinical, at least here in Texas. I can't speak for any other state. They are in the medical systems and the healthcare systems as well. And so their trusted presence, it supports the normalization of the HPV vaccination as a routine cancer prevention, and it improves the engagement among vulnerable populations. But also community health workers, they have a specific type of training where they often look at the entire being. They just don't look at, okay, they just have this one need. Community health workers have a holistic approach. Next slide. And so while we would love to see a clinical pathway in like an EMR system, that question was brought up to us as we were, kind of wrapping up our project is what if a healthcare system can't adopt this? And so we decided on like some toolkits that we can create while also providing like some like trainings, like train the trainer trainings and continuing education opportunities. So we will be creating a clinical toolkit, which Dr. Levy can speak more to that. We'll have a community health worker toolkit / patient navigator toolkit because community health workers and patient navigators, sometimes depending on where they are, they're doing the same thing. And that's more the trauma engagement and care coordination resources that will support that education, counseling, and vaccine series completion. Because also if a child presents in an emergency room that they have been sexually abused, of course, social work would be involved. And so we want to have a social work toolkit as well that they can provide that education on the HPV vaccination as well. And then lastly, community partnership toolkit, because when we're working with this population, we can't work in silos. We have to work together. And so we want to have a structure like referral pathways and training that will support the strengthening coordination with those community-based organizations that are serving pediatric survivors of sexual abuse. And so these are our references. And then if you have any questions on the clinical side, you can email Dr. Levy. If you have questions on more of the community health side, you can email me. Thank y'all so much.
Thank you so much, Celicia and Morgan, for that presentation and just really kind of looking at, pediatric survivors of sexual abuse, understanding that having an alert system is so important in identifying those that need that counseling, but also understanding utilization of community health workers and having those members that are already trusted members of the community and unifying that coalition to really address this cohort is just phenomenal. I just want to say, understanding using that lens of trauma-informed care and understanding how violence and stigma play a role. And just also there's cultural silence. So thank you so much for that presentation. I thought that was tremendous. And now we're going to go on to our last and final group who will be presenting on Badge Up for Health using Girl Scouts to promote HPV vaccine education. So please let us give a warm welcome to both Stacy and Jenny.
To start, I want to ground us in why this topic matters. HPV is associated with multiple cancers, yet vaccination uptake remains inconsistent across communities. At this point, the barrier is rarely a lack of scientific evidence. Instead, it's how prevention information is understood, discussed, and trusted in everyday life. Many families don't make decisions during a single medical visit. They leave the appointment, they think about it, they talk together and revisit the topic over time. So rather than focusing only on the clinical interaction, we began asking where those conversations actually continue and who helps shape them. We know the HPV vaccine is safe and highly effective, especially when started earlier, beginning at age 9. Earlier initiation improves completion rates, but it also changes perception. When introduced later, the vaccine can feel like a sensitive or complicated decision. When introduced earlier, it is more often understood as a routine cancer prevention. So timing affects not only protection, but comfort and acceptance, which makes the communication strategy just as important as clinical guidance. Research consistently shows that vaccination decisions are relational. They develop through conversations between parents and children, among siblings, and influenced by peers. For those conversations to work well, information has to be understandable across different ages and comfort levels. We also know trusted community settings reinforce information through familiarity and repetition. And peer-based learning helps individuals process information in a relatable way, not just hearing facts, but seeing someone like them engage with the topic. Taken together, prevention becomes less about delivering information once and more about supporting dialogue across everyday social networks. Despite strong recommendations, gaps remain. Misinformation and stigma continue to shape perceptions. Youth are often the intended audience but rarely active participants in prevention communication, and structural barriers still affect access in some communities. So the issue is not only awareness, it's engagement and trust. This suggested that improving prevention might require not only clearer messages, but also different messengers and settings. This direction aligns with broader public health priorities. National organizations now recommend starting HPV vaccination at age 9. There's increasing emphasis on countering misinformation and expanding community-based communication. And national goals highlight improving confidence alongside access. So our project was not separate from existing strategy. It explored how those priorities could be implemented in a practical, community-based way. We then considered where prevention conversations could realistically take place outside healthcare settings. The Girl Scouts offered a unique opportunity. A nationwide organization built around leadership, learning, and community service. They operate in familiar environments like schools and community centers, and families already trust these spaces. So we chose to work within a community setting where conversations could happen naturally rather than formally. Our strategy centered on older adolescents, 9th through 12th grade Girl Scouts, as communicators rather than passive learners. At this developmental stage, youth can evaluate information critically and reflect on how it applies to themselves and others. They also naturally connect groups, peers, parents, and younger siblings. Instead of simply teaching them about HPV, we involved them in helping communicate and normalize cancer prevention conversations. The goal was not only knowledge, but comfort discussing prevention. With that approach, we established two main aims. We partnered with a Girl Scout troop to co-develop a peer-focused HPV education toolkit centered on communication across peer, family, and community contexts. Importantly, the content was shaped with participant input so it would feel understandable and relevant. We also explored how acceptable and usable the toolkit felt to participants. Overall, we wanted to understand whether youth-led communication could meaningfully support prevention discussions. And with that, I'll hand it over to Stacy to walk through the program design and implementation.
And thank you to Jenny. You can go to the next slide. So what we wanted to do is we wanted to take our program and incorporate it into existing Girl Scout programming. And we had a troop where we said, we are going to see if teens even find this useful. So we were able to provide an incentive for participation by saying, hey, let's align this toolkit with an existing badge, the Senior Women's Health Badge, and then we will use those requirements to help guide development of the kit. So for those that are unaware of this badge, it's for grades 9 through 12, and the goal of it is to find out how to make health decisions that are right for you and what kinds of support exist to guide you. And it has 5 things that need to be completed. One of them is to look at tests that help women stay healthy, find out how fads and beauty practices can impact health, focus on techniques to help you stay emotionally healthy, take a closer look at a women's health issue, and get the word out on a women's health topic. Next slide, please. So our troop makeup. We partner with a Girl Scout troop located in Austin, Texas, and these girls were mainly Latina, first generation. They're going to be first generation college students. They were ages 14 to 17 in grades 9 through 12, and many of them expressed interest in healthcare and technology, and we used this as leverage of saying, hey, what a cool national project that you're going to get to work on. These are first immigration college students, and said that they're going to be able to help lead an initiative. So it was also really close to us to find a way to help previously disadvantaged students of having a national voice. Next slide, please. So this is a bit what our project timeline looks like. It's kind of wordy, but I'm just going to go over the general aspects of it. So from September to November, we set up a project with them, and what we would do is we would call into Zoom meetings to discuss things with the girls. So the first part was a letter to the parents and a learning questionnaire. We wanted to see how they preferred to learn about things. And we also wanted the parents to know that, hey, we're doing this project. And I think that that was really important because parents are already hesitant about this vaccine. They're hesitant with people coming in and talking to their kids. And so I felt like it was a way for us to build trust with the parents, and that, hey, somebody's coming in and doing this research with your kids, but we want you to know what's going on. And we had them sign it just to know that they received the information before we started anything. At the next meeting, what we did was we said, okay, let's see what they even know about HPV. And so we used a previously validated tool to assess for this. And then after that, we did a lecture. And this helped to get steps 1 through 4 of the badge. And we just talked a little bit about what is HPV, what are some signs and symptoms, how is it related to cancer, ways to prevent HPV. We talked about cervical cancer screenings, common misconceptions. And then after every single lecture, we took a survey. We wanted to know, did you find this information useful? Can you use this information? Do you like the way we presented this? Would you do this a different way? And the next time that we met, we were able to answer questions from a previous session. We had a lecture on media literacy because I think that's so important. Looking at vaccines right now and anything in the media, it's so hard to be able to determine what's real and what's fake. And I don't think that we have that infrastructure in the schools. And so that was really cool to be able to say, hey, we're actually going to teach you how to even be able to look up things and know whether something is maybe true, false, embellished, and things like that. And then we took a survey on that as well. And we discussed next steps for the next meeting. So another one that we did, so as I mentioned, these girls are primarily Latina. We actually had someone come and talk to them who was in their shoes before. She was a first generation college student. She became a women's health nurse practitioner, and she came and talked about her journey as a Latina woman. And how she views HPV and how she talks about HPV to her patients. And they really appreciated having that voice there and feeling like they were heard. And then we also talked a little bit about some beauty practices and fads to stay emotionally healthy, but that was not something that we're necessarily including with the toolkit. And then the last part was we actually had an in-person meetup. So funny enough, my husband had a conference there, and we were already planning on going to Austin at that time. So we were able to go in person and have a pizza party and finalize parts of the toolkit as well as test what they've learned about HPV in this whole entire program. Next slide, please. So the toolkit components that our toolkit is going to have is a little bit of an introduction to the toolkit. What's the purpose of it? We are finding ways to incorporate it into Girl Scout programming. As mentioned, we started off with the badge because we wanted to be able to give the girls something and them to have an incentive for being able to do this. But there are so many other health initiatives that can be introduced. We just wanted to start with one thing and then go from there. We also have developed a facilitator guide. So this is an HPV information sheet for the troop leader to be able to use. We got input from the troop leader for this, as well as possible supplies and discussion topics that we're going to talk about, as well as a letter to the parents to let them know, hey, we're going to be doing this type of programming and optional add-ons. Next slide, please. So some of the discussion topics, Jana, I don't know if you're here, but if you are, shout out to you. She works with cancer pathways, and we chose to work with her because she has prior experience in working with Girl Scouts. She did a program in Atlanta where it was teaching them about the HPV, what is HPV and the vaccine. So we were able to partner with her and use some of her materials that she had developed. So she has something called Cancer Happens Curriculum. And what I absolutely love about her models and curriculum that she has developed is that all of the modules that we use were aligned with 9th to 12th grade national education standards. And so that was a way for us to know, hey, we're actually getting the information to them in a way that is already approved by our education system and catered towards their level. Next slide, please. So this is some of the stuff that when I said extra things, we also tried to make it really fun for the girls. And we said, if you help us develop some things, we can bring things. So the one all the way on the left, cancer prevention through vaccination, asked me about the HPV vaccine. That one was a sticker that we designed and gave to them at the end along with their badge and the pizza party. And so they could use whatever they wanted with the stickers. And then we came up with some other designs that we're planning on putting in the toolkit in case they want to use anything for promotion or talk about anything at any community events. Next slide, please. So early impacts and lessons that we learned. Next slide, please. So not as far as knowledge and awareness, every single one of the participants learned new information about HPV and the vaccine that they didn't know. 90% of them talked about the importance of learning about the HPV and vaccines, and we were also able to clarify a lot of common myths. A lot of them didn't know that men can also be affected, and we were able to talk about facts such as, can HPV affect someone's life? Is it long lasting? What can happen? And just answer various different questions. We also were very excited that around 85% found our content clear and engaging. That's really exciting when you're working with teenagers to know that they actually think that what you're doing is interesting and kind of cool. They were able to ask really thoughtful questions and suggested a lot of different interactive formats that I hadn't necessarily heard at and Jenny hadn't heard at before. And it also, because we continued to meet with them and we also met with them in person, we developed a relationship with these girls. And it came to a point where they were very comfortable discussing health topics with us. Next slide, please. So some challenges, balancing sensitivity and accuracy. So delivering honest HPV education while remaining age appropriate. So we had to go from a cancer prevention focus because we are not allowed to have conversations about sex in Texas. Particularly in the schools, you're not allowed to have those conversations. I also really didn't want to have that conversation with people who are already with immigrant parents who may or may not trust healthcare providers, may not trust researchers. We didn't want to even go into that realm. And so we tried to we did not talk about any of that. We also, wanted them to be engaged without being overwhelmed. So it's a lot of information. These girls are in high school and may not necessarily have the vocabulary that we have when talking about HPV or any type of medical things. And so I think that's why it was so cool that we were able to partner and use those resources that are already with the guidelines for the Department of Education. And we tried to use really simple, calm language, being able to foster curiosity and safety. And also cross-institutional coordination. So trying to co-lead this project across different states and institutions was a little rough, but we were really glad that the girls were able to let us come to their meetings and talk then. And it just so happened that Jenny and I were able to call in at all those times. So that worked out. Can we please have next slide, please? So the next steps, we want to continue to refine our content using participant feedback to help ensure age-appropriate and very engaging delivery. We want to expand our reach with this information through the publication of this toolkit for Girl Scouts to be able to use nationwide. And like I said before, we want to be able to put this into other types of Girl Scout programming. It just so happens that we did the badge so that we could have a start. We also want to strengthen our partnerships. So organizations such as Team Maureen and the Massachusetts HPV Coalition to support broader HPV prevention. I will thank Kelly later, but it's because of her, and I think she's here, that we even came up with this idea because she had talked about doing programming in high schools, and she's on Team Marine, and we said, that would be really cool. And she had also talked about how she wanted to reach out more and do something with the Girl Scouts. And so we worked with her to try and come up with a solution of how we could incorporate this information into Girl Scouts as well as get them excited about participating. Next slide, please. And once again, we want to thank everyone at the HPV Roundtable. Barbara Schuler, thank you. Dr. Irvs, my mentor. Jana, thank you so much for letting us use your materials. Devin, who is Jenny's boss. Kelly Welch at Team Marine, and the Girl Scouts of Austin, Texas. Next slide, please. And because Jenny wasn't able to be here, she allowed me to put a QR code for her LinkedIn. And this is also her email if you would like to contact her. And my information is there as well.
Well done. Great presentation from all our 16 fellows, the 8 groups that presented yesterday and today. Good afternoon, everyone. I'm William Callow, Associate Professor of Public Health Sciences and Family and Community Medicine at the Penn State College of Medicine, and Advisory Board Member for the Emerging Leaders Program. It is my pleasure to moderate this Q&A portion of today's showcase. I'll be inviting all fellows to be back on full screen so we can start the Q&A session. I would like to start with group number 1, and for all our participants, if you have not posted any questions yet, you are still time to have that. I will be reading your questions, so please use the chat box or the Q&A feature for any last minute question that you have for our panelists. I will be asking the first group, Lauren and Anne. Actually, there's a question from Heather Bryan, and I saw that you answered a little bit of that in the chat. Heather asked, I wonder if children with medical complexities need 3 doses for childhood cancer survivors. For example, the Children's Oncology Group recommends 3 doses regardless of age initiation. And Lauren, I saw that you posed a specific response for a particular case that 2 doses will be enough. Question that I have, if you answered that from Heather for all the benefit of all the attendees here, but the question that I have is, how do you think your toolkit and your program will advise these pediatric specialty providers to understand case by case how many doses that kid will need?
That's a great question. So I don't know if everybody saw my answer to Heather. I think HPV 3-dose series depends on the child's specific diagnoses and if the patient is immunocompromised. For instance, cancer, HIV, immunocompromised patients, they require 3-dose series. But an example of, let's say, a child with G-tube dependency or cerebral palsy, I think a 2-dose series should be sufficient. Part of the action plan requires or was thought about as like accountability partners and just kind of increasing that collaboration between primary care providers and specialists. So, depending on the diagnoses and the recommendations, again, there's limited information in this specific group. I think that collaborating with the primary care providers and kind of tailoring, how many doses are needed specific to the patient and their diagnoses or treatments and needs would be useful. I don't know if that answers the question.
Sure. Yeah, thank you. I know it's a complicated question, and it
It
depends.
is complicated.
Yeah. I have a follow-up question. You or Anne can answer this one. I look at your action number 3. You're going to be promoting the announcement of training as one of the tools that providers can use to recommend vaccination. One of the announcement approach steps, step number 1 is to answer common question that parents have about HPV vaccination. I have been working with the announcement approach training for many years, and I would imagine that you would need to maybe modify or adapt that kind of a set of common questions and answers to these medical complexities. That is something that the announcement approach training does not have available right now. Have you thought about that? How do you envision adapting or expanding the set of common questions to bring new things? For example, my kid is taking this medication or going through that treatment. How safe is to do this vaccine with that? I would imagine that you will need to go beyond the existing set of questions and answers. Tell me more about that.
Again, another hard question. Thank you, Dr. Kell. So I think, again, one of the examples, like as far as like existing questions, we do have to be up to date on, who our patient is, what they're on, what the management is, and what their plan is. But our common goal really is to prevent cancer. I don't think there's a specific script, because every child, like I said, the medically complex child, it has 2 different diagnoses. It could be a realm of things, right? So it could be autism and asthma. It could be child with traumatic brain injury. And, like my example was cerebral palsy or premature infant with lung issues. So it really depends on the case itself. And again, like collaborating with the subspecialist and kind of doing what's best for the child and the parent is key. I also think like a lot of the times, especially my medically complex patients, the parents are like, oh, my child doesn't need that. They're developmentally delayed and they're never going to need this. So kind of addressing those types of questions might be included. Again, we do need more information on this topic because there's such limited data and there's such gaps in it. And oftentimes, part of the reason why I thought this was a very important population is because we have this rapport with them. I see these patients like on and pretty frequently, and they have a lot of follow-ups with other subspecialists. There is this gap between like the subspecialty care and the primary care, and kind of bridging that would really be super helpful and making sure that we're all on the same page for the patient. Okay, that was a long-winded answer. And again, very hard question. I don't know if I answered it.
Thank you. I'll move. Great response, and great project that you have developed. So I wish you success, you and Anne, moving forward. Let me ask the next round of questions to group number 2, and again to our attendees, feel free to put some questions or comment to our panels in the QA box or the chat box. For group number 2, the question that I have, I work at a cancer Center or Cancer Institute. And this is childhood cancer survivors is one of the populations with low vaccination rates, not only HPV vaccine, but mostly all childhood and adolescent vaccines. There are so many projects happening right now. I can tell in my hospital, for example, for flu season, we want to do programs about flu season for these type of patients. For HPV vaccination, we always talk about the bundle approach, right? So the question that I have is that taking advantage that there are many other vaccine programs happening in pediatric cancer centers or hospitals. How do you see your proposed program and toolkit to take advantage or insert other vaccines to make it more comprehensive to this population?
Yeah, Braga, I'll go ahead and give my thoughts. One of the conversations that we had, Dr. Kayla, was with our survivorship care clinics that is specifically, looking at pediatric cancer patients as they're kind of coming through treatment and then following up with them many years after their cancer treatment has concluded even. And one of the things that they identified in that conversation with them is that the information that they provide to pediatric cancer patients or all cancer patients that are kind of moving towards survivorship is blanket information about vaccinations after treatment. And so I think, to your point, within that context, a lot of information is conveyed, but specifically for HPV vaccination, it was not necessarily highlighted for pediatric patients, other than the conversations that we had with oncologists and the fact that they would, stated that they would recommend to their patients that this is another vaccination that you need to get. And so I think updating the information that survivors are receiving in those survivorship care clinic models, that at least MD Anderson takes that approach, would be kind of an initial step. What I thought was interesting, though, kind of in terms of how can you adjust the workflow process? One thing that, at least within the system that we were using, which was Epic at the time for MD Anderson, is that many of the triggers around follow-up, so a lot of the notifications that potentially would send out reminders or things that could be discussed with their physicians, were not yet turned on. And so that was one thing that the Survivorship Care Clinic was kind of looking into, is how can the system itself ensure that there's conversations or information being transmitted to the patients and their families around HPV vaccination, if it's due, in the time window for eligibility post-treatment, as well as other vaccinations that are coming up. And so I think it's going to be interesting to see how we continue to utilize, I guess, the system that we have in place to make some of those reminders happen more frequently for patients. And so hopefully more conversations or more questions will be coming to the oncologist specifically. And I think what's interesting is we spoke to some groups that have done research in this area between cancer centers and how they're working with primary care offices and hopefully sharing information between the two within their EMR systems. And so I think that that's another potential, is that an order can be placed for a vaccine within the cancer care system that would actually go to the primary care office too. So making that connection between the centers in itself. But ultimately, I think that there's a lot of education that should be happening around vaccination post-treatment for cancer survivors, and that HPV vaccination can be a focal point. And we definitely seen that in conversations that it's not right now. And so I think for the future, it's something that we could definitely work on.
Thank you, Blake. I have more questions for you, but we have limited time, so I'll email those to you separately. I'm going to ask 2 more questions for group 3 and 4. For group 3, there is a question in the chat by Lauren, Morgan, and Alicia. This is a great care path and seems like it requires careful coordination, collaboration, and many resources. In what setting do you think this care path would work best? Urban settings, rural settings, or both, or maybe large academic settings? I know that you answered that question, but if you can just say that to our large audience and explain your response, that would be great.
Yeah, to start, as the one who is on the clinical side most often, Where I saw these alert systems work really well to facilitate care coordination was at the academic center where I am in training. I will say, though, that our center serves a very large catchment area of a rural population. And we have found that it's actually very effective in facilitating follow-up care for our patients who travel a lot further to receive their medical care. But it does require a fair amount of resources to have all of the people in place to help make that happen. And so I think that it could be implemented in other settings, but it does need to be a setting that has some of the resources, in spite of the fact that it might be a setting where a lot of patients face barriers to healthcare, which is a challenge I recognize for health systems to address.
Yeah, Morgan, I have a follow-up question to that one. I want to
Yeah.
ask you that, and I think you mentioned the importance of having those resources. And the one of us who work in health systems, I think more recently, for whatever reason, we're throwing every problem that we have, we're throwing that problem to the community health worker or the social worker. I'm
Yep.
seeing that very recently. So I'm thinking, and sometimes they're overworked or you don't have enough CHWs in your system. What other healthcare professionals can be involved if CHWs are not available or overworked? Have you think about that?
I had not thought about that specifically in this context, but I will say that in general, I have found that something that can work really well in terms of helping with things like surveillance and follow-up and next steps in care, or even often being part of the inpatient care teams, has actually been having advanced practice providers involved in these pathways for things like routine surveillance visits, um, or having specific like screening programs that they see all the patients who are involved in, and nursing as well, just more broadly speaking. I think those are resources that if we have the adequate um, number of team members to actually do that can be very effective, but it should not be done in a way that overly burdens somebody involved in it. And that's a huge problem. I would agree. We cannot push every problem onto one person and expect that it's
Yeah.
actually going to fix anything.
Yeah. Thank you, Morgan. Very representation. The next question is for Jenny and Stacy. I have two questions here. One from Christopher. He wrote in the chat, how do you build trust when delivering health information to teenage girls?
So I think one of the things that we did really well was that um, we made this as educational, not promotional. We said, we understand that you girls want to go into the healthcare setting or technology. And so we're going to use this to empower you and help build up your resume and show you how to help us develop something, and gave them an opportunity that they would have never had. When this is all said and done, it's really cool. Now they can put on their resume that they have helped to develop a national toolkit that's going to be published. And I also think that I hope we did a good job with incorporating their parents. I think that was really important of saying, hey, this is a letter to what we're doing. We gave them information about the HPV Roundtable and said, it's with the American Cancer Society. And the parents said that they really trusted that we gave them that information before we started anything and before we had any conversations with their girls. I also think some of the trust helped in that. One, I come from the type of neighborhood that they're from. I might not look like them, but I kind of understand of being from a background like that. And I also think that us having people come and talk to them that look like them, talk like them, and came from their background, and them able to ask questions and seeing people be successful in that regard also helped. Um, but yes, I think a lot of those things helped.
Thank you, Stacy. My last question. You are doing a beautiful job with Girl Scouts, but my question is, what other kid groups or clubs beyond Girl Scouts can benefit for expanding this type of program to them?
So funny enough, the troop leaders also had conversations with people at the school. So HOSA, which is the healthcare organization there, is actually really interested in what we're doing too. And at the end of every single school year, they have a health fair. And so they're actually talking about working with the Girl Scouts to be able to develop HPV education programming into that health fair at the end. And we are planning on bringing that group in too.
Good, thank you. And I'm seeing that you are answering some questions about Girl Scout membership and all that there in the chat. So great. Thank you. That's the end of the Q&A session. So we can move to the next slide, please. Next slide. I want to thank you to our Emerging Leader Advisory Board members who have guided and provided mentorship to our fellows and the program overall. We could not have had such successful projects and phenomenal fellows without each of these individuals. Thank you. And I want to congratulate this amazing cohort of 16 fellows for all they have achieved in only 1 year. And thank you for serving today as panelists in our showcase. Congratulations to you all for such amazing projects. Next slide, please. To our guests, as a reminder, the webinar was recorded and link will be available soon. We just ask that you please take a moment to complete the evaluation of our session today. The link will be available after we conclude. Thank you for joining us and have a wonderful day. Thank you.